Hi, my name's Dr. Ross Hauser. Welcome to the Hauser Neck Center here in Fort Myers, Florida. Thank you so much for watching this video. I'm asked a lot of times if ligamentous cervical instability, or in this situation, if ligamentous lumbopelvic instability, is it causing my symptoms, right? Because that's always the question. Since we're talking about tethered cord, the normal symptoms are somebody has low back pain, they have leg pain, so no problem there that can be from ligamentous lumbar instability or ligamentous pelvic instability, because that can irritate the lumbar nerve roots or the sciatic nerve, right, causing pain down the leg. Well, once you start getting bowel and bladder symptoms, like when I was in med school and then I was in residency, I did my medical school at University of Illinois, graduated in 1988. Then I did my residency at Hines VA Hospital and Loyola Medical Center in Illinois, and that was from 1988 to 1992. When someone had bladder or bowel symptoms, like they were getting incontinence or they were getting urinary frequency, or the bladder or the bowel was involved, it elevated the importance of that you have to make the right diagnosis. And then often the treatment involved something more invasive than I would do as a physiatrist, like it would involve surgery, right? The standard is, if you have symptomatic tethered cord syndrome, the standard, or what's the accepted standard of medical treatment, often with this condition, it's surgery, right? But you got to realize I'm often the doctor of last resort, so who do I see? I see people, they've had Chiari surgery, they've had fusion surgery, they've had low back surgeries, they've had tethered cord surgery, and they still have symptoms. Like, I'm not seeing the people who had these surgeries and then they're better. And I know there's plenty of people that have had tethered cord surgery and they feel better. But always know Dr. Hauser's bent. He sees the people that failed the surgery. The surgery might have given them more symptoms, or the surgery lessened the symptoms, but they still have symptoms. But I'm always amazed at, even with tethered cord, we're not asking the question, why is the filum terminale? So in most cases, the spinal cord is attached to this string-like substance structure called the filum terminale that connects on the coccyx. Like, why is it so thick? You know, like, in other words, if we're saying tethered cord is from that cord being really thick, why is it thick? Well, it could be it's thick because it's trying to stabilize something. Like, it's actually trying to stabilize the spinal cord because the spinal cord is under so much tension. Or the filum terminale is at the sacrum and at the coccyx, there's extra motion. So that's one of the reasons why I put this up here. Basically, is the person's symptoms due to tethered cord, or are they due to lumbopelvic instability? So I think you guys who dive deep, and when I do these long videos, I don't have a watch. Like, I don't have a watch. So it just means it's just me talking freely. And when you dive deep, you realize that some of the people, the problem actually might be an instability issue, and that instability issue is what has to be taken care of to resolve the symptoms. Can prolotherapy help in the treatment of tethered cord symptoms? It's kind of like, can prolotherapy help in the treatment of chronic Lyme disease? Well, if the symptoms are due to Lyme disease, you've got to get the Lyme disease treated. But if the symptoms are due to ligamentous cervical instability, you've got to get the ligamentous cervical instability treated, and one of the treatments is prolotherapy. So if a person has nerve irritations, the lumbar nerve roots, the sciatic nerve, the sacral nerve roots, they're irritated because of ligamentous lumbosacral or lumbopelvic instability, then of course prolotherapy should be able to help it. And then the other notion is, think of this too, this is even the more interesting part of it, is according to Hauser's law number 5, so we're going to talk about Hauser's law number 5. According to Hauser's law number 5, that if you have a chronic disabling symptom, so let's say somebody has a chronic disabling symptom of, I have horrible pain down my legs and I'm having some bladder issues or bladder pain, and the urologist can't figure out why my bladder hurts or why I have burning with urination or why I have urinary frequency, like I'm peeing all the time. Hauser's law number 5 is that if a chronic disabling symptom is not due to nerve dysfunction or a fluid flow issue, the symptom is caused by an organ losing its connective tissue support. And you might say, well, how does that relate to like the rectum and the bladder? Well, realize the rectum and the bladder is in the pelvic ring, and those organs are connected by ligaments, by connective tissues to the bones of the pelvic rim. Well, what keeps the pelvic bones from moving excessively is what? The pubic symphysis, the sacroiliac ligaments. So imagine a gal, and a lot of the people with tethered cord, right, it's gals. They're more loose jointed in general than guys. They have looser ligaments, and especially if somebody's had a few kids, and especially if somebody has Ehlers-Danlos syndrome, or they have hypermobility spectrum disorder, or they have joint hypermobility syndrome, or some other condition that causes loose jointedness. Let's be honest, man, their bladder is going to be going bing, 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 bing. Their rectum bing, 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 and that can cause a lot of symptoms. Like they're going to get extra motion just by doing normal activities in those organs, right? So the end of the spinal cord is supposed to be around L1. Then in a tethered cord, there's something down here pulling it down further. So on MRI, you see that it's pulled down further. And sometimes there's a fatty growth or there's some genetic problem that has to be taken care of by surgery. Okay, common features of tethered cord syndrome: progressive low back and leg pain and numbness, as well as bowel and bladder symptoms. Some studies have shown over 90% of bowel and bladder dysfunction. Most of the pathology is thickening and fat accumulation of the filum terminale, which is the end of the spinal cord at L1. That's what gives it stability basically to the coccyx. There's improvement in symptoms in 57 to 85% of patients who get surgery. Now realize what they're saying is it's symptom improvement. They're not saying cure, right? So the cure rate's going to be way, way less. So, okay. So somebody has tethered cord syndrome. It means they have some symptoms that they're saying is because they have this tight filum terminale that's pulling the spinal cord down. Then if I snip it, right, I get surgery and I snip it, based on this, it seems like you could say realistically the cure rate is absolutely below 50%. And most people just get some symptom improvement. Now, so that would mean that the underlying condition likely that's causing the filum terminale to thicken probably still continues. And I would say that condition is ligamentous lumbosacral, lumbopelvic, lumbosacral instability. Okay, this is good. Presenting symptoms. Let's look at these presenting symptoms. Some of them are kids. 70% have neurologic symptoms, back pain. Urologic symptoms, 2 out of 3. These are all symptoms that could occur just from instability. This is just me, but it seems like every time I scan somebody, like I order an MRI test to look for tethered cord, I never find it, but they have symptoms compatible with tethered cord, which is interesting, isn't it? Like I do the MRI test for a tethered cord and I don't find it, though they have these kind of symptoms. This is from a study, or this is from a paper. It's not our thing that we made up here. They're just saying that in people with Ehlers-Danlos syndrome, so it says, this is a paper from Dr. Gensemer. It was published in July 2024, I think Frontiers of Neurology, yeah. Co-occurrence of tethered cord syndrome and cervical spine instability and hypermobile Ehlers-Danlos syndrome. So basically what the authors are saying is, we're finding that people that are loose jointed, they have basically ligamentous cervical instability, and then they have tethered cord, and there's these common symptoms that they have. You know, so that again is just intriguing to me, because let's be honest, if you have a destructive or dysfunctional change anywhere in the neurologic chain, so in other words, the neurologic chain is the brain, the spinal cord, then the peripheral nerve roots. So if you have an elongation of your neck because your neck isn't in the lordotic curve, but it's flexed forward, you have a reversal of the curve because you look down at cell phones too much, that's going to be putting tension on the spinal cord and potentially on the nerve roots. Then you also get ligamentous lumbar instability or pelvic instability. That's also going to be pulling on the nerves. So now all of a sudden you have it pulling up here, pulling down here, pulling over here. All these things add tension, and then the nerves don't work correctly to the bladder, to the rectum. You get pain down the leg, you get back pain. So one of the treatments to consider should be restoration of the curves, and as well as prolotherapy to resolve the instability. And this just is me just showing that even chronic Lyme's post-whiplash ligamentous cervical instability, there's a lot of commonality in the symptoms. So it makes you think, geez, if you're diagnosed with chronic Lyme, tethered cord, chronic whiplash, that you should consider thinking about getting an evaluation for ligamentous cervical or joint instability or lumbosacral instability, because the problem can be there. So this is Hauser's law number 5. We see a normal, stable pelvis. We see the rectum. We see the cervix. We see the bladder, right? The ligaments are tight. The ligaments attach. This is the pubic symphysis. This is a sacroiliac joint here. If you have extra movement of the bones because the pubic symphysis is lax or injured, or the sacroiliac's injured, there's going to be tension here. I just call it like forced distribution dysfunction, meaning that when you do normal activities, the bladder is going to move more, the rectum's going to move more, the prostate could move more, the cervix moves more, the uterus moves more. Because think about a person who they have bleeding all the time from the menstrual cycle and nobody can figure out the cause. Well, if the gal's loose jointed and all the time the uterus is sloshing around and getting all kinds of tension on it that it shouldn't, you could see where that could screw up uterus function. I used to see quite regularly, I don't now, but I used to see quite regularly like 25 years ago, 20 years ago, I'd see guys coming in with, I got prostatitis, my prostate, I got burning in my prostate, and the urologist didn't know what to do. Like, in other words, the cultures were negative. It's like a person having burning urination, but there's no bacteria. Like, they keep testing the urine and it all comes back sterile. Well, the burning can be just from, there's extra tension on the prostate or tension on the nerves that go to the prostate, the autonomic nerves that go to the prostate or the bladder, that can be a cause. All this stuff can be caused by ligamentous pelvic instability. Somebody has cystitis, so they have cystitis. They have interstitial cystitis. The urologist says there's all kinds of redness in the bladder when they do a cystoscope, and nobody knows the cause. Like they don't know the cause. Well, the cause could be there's just basically tension on the bladder caused by ligamentous pelvic instability. And so if you stabilize the pelvis, right, you get a Sorolla belt, you get a Sorolla sacroiliac belt, you get Prolotherapy in the loose ligaments, then there's not tension on the bladder, the prostate, or the rectum. You could see where, at least theoretically, that could cause the symptoms to go away. So basically here, see how in this drawing the spinal cord is at L3, that would be tethered cord. It means the cord's pulled down from L1 to L3. This shows the filum terminale, and the filum terminale extends from the end of the spinal cord to the coccyx. Its purpose is to stabilize and protect the spinal cord. It transitions from the filum terminale to the end of the one at S1, S2. So basically, to diagnose tethered cord, sometimes you can see it on a regular MRI, but a more sensitive test is to get a regular MRI and compare it to a face-down MRI. So see here where A is you have a normal MRI where you're laying face up and see where the spinal cord is. And then B is when you lay face down. When you lay face down, the spinal cord goes more toward the front. It goes more anterior. When the spinal cord isn't tethered or something yanking on it, it has normal motion. So in other words, in non-tethered, the movement of the spinal cord is greater than 10%, comparing the supine to the prone. So they're just saying like this motion is greater than 10% of the canal distance. When it's tethered, there's almost no difference in motion, and that's basically in ventral motion. So that's motion forward. So in that tethered cord, you get a supine MRI and you get a prone MRI where you're face down, and the MRIs look the same, like there hasn't been any motion of the spinal cord. Now this just shows that if you have a reversal of the neck curve, that yanks on the spinal cord too. And so cervical dystructure or a breakdown of the cervical curve, just like a breakdown of the lumbar curve, it can put tension on the spinal cord. And if, like for instance, like let's say somebody has just a horrible forward head, they have a terrible forward head, like it starts when they're 12, now they're 32. Like for 20 years, there's been tension pulling up on the spinal cord, You could see where that could be a contributing factor to the filum terminale. Like it just can't have the spinal cord going up and having all this tension. So it might compensatory thicken to keep it pulling down. It'd be like when somebody pulls your arm this way and you don't want to go that way, you pull back this way. Anyway, this is tethered cord with and without lumbar instability. So in other words, this illustration, the person has a nice lumbar curve, but the cord is tethered. It's below L1. It's at L3. Where here, they lost the lumbar curve. So they lost the lumbar curve, and that's the reason that the cord is tethered down here. So when you sit on, like when your back isn't supported in the chair, and I'm just going to illustrate like the slouch. I think the number one cause of this feels kind of good, but I got to be a good example and go like this. But you know, like when you're supported back here, you know, even if you slouch, the chair is supporting you. But if you slouch like this, like, you know, we're watching TV, you got the clicker, you got the popcorn, you know, you're like this, or you're like this with a cell phone, the slouching causes you to lose the lumbar curve, lose the cervical curve, and all these things put tension on your spinal cord. And it can give you symptoms that are similar to tethered cord. So this just shows, this is how it's supposed to be. Good lumbar curve, the spinal cord ends at L1, so this is normal. That's a non-tethered spinal cord. So when you lose the cervical curve or you lose the lumbar curve, basically there can be tension on all these nerve roots, giving you low back pain and leg pain. And a lot of times the leg pain can be really, really bad when you're laying down at night. Like right now, I'm flexed at the waist. That relaxes the nerves here. But when like the sciatic nerve, but when you extend at night, that's when a lot of times the leg pain can be really bad. That's a sign that there probably is some lumbar ligament injury. And sometimes you know that because the muscles are always stiff, or if you have clicking, popping, grinding in your lower back, that's a sign that you got ligamentous lumbar instability. Or if you have it in your neck, clicking, popping, grind, that's a sign of cervical instability. Oh, this is some testing that we do in the office. So with ultrasound, we can measure how far apart the pubic symphysis is, how far apart the sacrum is. So in this person, the sacroiliac joint is about 5 millimeters. That's a little bit elevated. So the person has a little bit of sacroiliac ligament injury. This just kind of shows that the ligament support is more like a mesh. We talk about sacroiliac ligaments, lumbosacral ligaments, but just know it's really a mesh. So that's why when a person comes for prolotherapy, it's a lot of injections. You're doing the whole sacroiliac joint, you're doing the lumbar, spine, and what we can do is move the hip. We can do all kinds of things to see, does the pubic symphysis stay together? Is there an increase in the joint width of the hip or the sacroiliac joint? So we do dynamic digital radiography. So we might move a person in certain ways or have them squat or do things to stress the joint to reveal the ligamentous pubic instability, hip instability, sacroiliac instability. So even on still x-rays, you can sort of see signs or symptoms that there's extra stress there. Like when you see this white bone here, you see extra white bone there, it means that the body's feeling extra pressure there. So if the body's feeling extra pressure there, it's like, why? The person's not an athlete. They're not, in the NBA. Well, when you have ligamentous joint instability, the pressures on the joint go way, way up, and that's what causes the degeneration. Sometimes we'll see this massive separation. So this is L4, L5 anterolisthesis. So this is quite a large anterolisthesis. This would be an area that should respond really good to prolotherapy. Again, just showing, you could see where we have the person, doing different maneuvers to reveal that the pubic symphysis is separated by more than 3 millimeters. And we see them 8 millimeters, 7 millimeters. So that would mean a 7 millimeter, they have a 4 millimeter diastasis or separation. So the treatment is prolotherapy and then of course some kind of a belt like a sacroiliac belt to keep it together. This is the normal architecture of the bladder, the cervix and the rectum. And again, if you got ligament injury, it can cause dysfunction of the prostate, the rectum, the cervix, the bladder. It could cause all these things: irregular menses, fecal incontinence, infertility, pelvic floor dysfunction, perineal pain, pelvic pain, polycystic ovarian syndrome, urinary frequency, urinary incontinence. Because again, even the ovaries are going to go bing, 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 bing if the pelvic support isn't good. And then prolotherapy injections are given where the ligaments are. The most common ligaments that we treat in the lower back are the facet joints, which are covered by the capsular ligaments. We would also do the sacrotuberous, sacroiliac ligament. And then obviously if there's a neck problem, we would have them do better ergonomics or posture with their workstation. That's very, very important. All of us need to make sure that we're using our muscles. Like when you're just sitting and you're not using any muscles, you're probably putting the strain on the ligaments and the ligaments are going to get injured. So you're really better off, when your muscles are contracted, then of course the force on the ligaments likely is going to be less. So we all need to have a looking up lifestyle, because a looking up lifestyle is healthy. A looking down lifestyle normally leads to illness. In summary, I'm just saying that if you're somebody who's been diagnosed with tethered cord syndrome, by MRI documentation, you do have the condition, it doesn't mean definitively that that's causing the symptoms. So you might also want to get tested for ligamentous lumbosacroiliac pelvic instability, because if you have that, you might want to try treatments of that first. That's one. Then two is, if you've been diagnosed with tethered cord syndrome, but you don't have MRI documentation that you have it, it's kind of conjecture. In other words, the surgeon might go in there and there is things like scarring and things, but again, maybe a better approach is to get tested for the various instabilities. And if you have the instabilities, maybe doing the non-surgical treatments like prolotherapy, like physical therapy, proper posture, and all the other things that go along with non-surgical care first. And so in our clinic here at Caring Medical, there definitely are folks that we see that have either had tethered cord surgery or they've been recommended that we end up doing prolotherapy, and many of the patients do feel better, after their pelvis is stabilized, their lumbar spine stabilized. I have a special guest today, Dr. Marcia Perretto, who's a physical therapist who's an expert in ligamentous joint instability, Ehlers-Danlos syndrome. And then we're personal friends. We've known each other for a long time. When I first came to Florida, which of course was 10 years ago, Marcia was one of the first people, Dr. Perretto was one of the first people that I contacted, and then we did some lectures together, and over the years we've shared clients together. I wanted to talk today about tethered cord syndrome because it's interesting. I've been a doctor since 1988, so I've been a doctor for 36 years, and it's just interesting to me, probably from 1988 to like 2016, I almost never heard about tethered cord. Then in the last 8 years, it's been like, geez, like all of a sudden there's like, maybe I have tethered cord, maybe I have tethered cord. So I just wanted us to talk about your experience with tethered cord. Like, what do you think causes it? And I'm not talking about cases where there's a big fatty tumor there or this or that, but just, obviously the people that get tethered cord seem to be, they're loosey-goosey. And I just wondered, your experience as a physical therapist. Then I'll sort of give you, my take on it. But we do know, the clients have a lot of symptoms. They have radicular symptoms down the leg. They have low back pain. They have, some of them have bowel bladder issues. Yeah. But if you have any experience, what's your experience been for the patients who get surgery? Because a lot of people, they sort of like that's in vogue right now, to get surgery for tethered cord.
Well, I have experience with the pre-op and the post-op. Okay. So I have seen both ways. I think I have had those that come into the office that don't know they have tethered cord, right? They came in for, I have Ehlers-Danlos, I think I have Ehlers-Danlos, I have hypermobility spectrum disorder, or I think I do. And then on examination, when we put the symptoms together, we do the neurological examination, we realize that the pattern is quite suggestive, right? And we also know that patients with Ehlers-Danlos syndrome, hypermobile Ehlers-Danlos syndrome, have a much higher tendency to develop tethered cord. It's still rare, obviously, we know that, but seems to be more prevalent on this population due to the connective tissue. So obviously there will be that patient that says, my lower back hurts, my buttocks hurt, pain down the legs, weakness and heaviness to the legs, pins and needles. If the tethered cord is at the thoracic or the cervical level, a little more uncommon, but it's still possible. And I have seen more than I would like to see. These patients will also present weakness to the arms, pins and needles to the arms, and clumsy gait, and difficulty balancing, all those things. So I have seen that, and obviously we do a referral accordingly to the proper neurosurgeon for proper assessment and testing. And then the post-ops, right, when they come back. I think one of the signs that I see the most on the a little more advanced ones will be like, I can't straighten my knees because it hurts my back. I think that's one of the big complaints I hear.
Does the person have more symptoms, in your experience, when they're laying down at night, or they're walking, or when?
It's mostly, the biggest complaint I get is like, I have a hard time standing for periods of time. I have a hard time walking. I feel my legs weak, heavy, you know, and sometimes it will affect already, if it's more advanced, will affect circulation and will cause like autonomic symptoms.
If you had a new client and you suspected they had tethered cord, and you were explaining it to them, how would you explain it so they could understand it?
I would explain to them that's like if when you hurt yourself, you have a surgery, there is like scar tissue formation. I would teach them that more or less. It's like when the spinal cord kind of becomes attached to the tissues around it, and when you kind of move, bending or hyperextending, it gets tugged, and that will cause more symptoms. And obviously, if it's more advanced, even just in neutral position, you are going to develop symptoms just by sitting down or things like that.
Yeah, I think we don't realize, but every time we move, even the spinal cord has a bunch of movement. So anything that causes spinal cord tension, like you move, but the spinal cord can't move normally. So do you think the cause of it, in cases where the MRI doesn't show like, you know, fat or something attaching to the end of it. So the conus, the end of the spinal cord, attaches to the filum terminale, which the reason why I brought this was, you know, it attaches somewhere in here. So so in other words, the end of the spinal cord attaches to the sacrum and the coccyx. So I wondered, well, let me ask you this. Say you had somebody who had tethered cord, they don't have like a fatty tumor or something, or they didn't have surgery somewhere down here, and then so there's not scar tissue, and you suspect it's some kind of pelvic distortion, instability. Do you feel like with the right exercise or the right physical therapy or the right prolotherapy, do you feel like it could help it a lot, resolve it? What's your thoughts?
I mean, by the time those patients get to us, they are far gone into the process of the scarring of the area. So it's a little harder to manage those, but we have been a little more successful in a couple cases. Tissue responds to tension, right? So it's tension over time to remodel the tissue. If you're gentle enough, and if you build the tissue and build the abdominal support and the pelvic strength and all that, we might have been able to actually extend the quality of life of those patients without having to have surgery. But those are the cases that we can actually do an MRI and we see that there is a tethered cord. There will be those cases that we don't see that the tethered cord is there. The tests are completely normal, which is a huge thing with EDS patients, right? There is nothing there.
Yeah, that's a good point. That's a good point. Yeah, that's a good point.
Yeah, that's due to the tension and the kinking as you bend, as you move. Like I explained to them that it's like if your arm is moving, so your spine is your arm and your dura and the tissue around is like your sleeve. And your spine needs to be able to slide. If it's attached due to scar tissue, you're going to be able to see and you're going to have adhesions. But if you can't see because it's due to tension, due to scoliosis, due to something else, so it changes the picture a little.
This is just my bent. You know, we're talking about this. I mean, we've had conversation before, but this is the first time sort of in depth. This is just me. I'm just saying this is my Hauserian, you know.
Philosophy.
Yeah, this is Hauserian stuff. When tests are normal, I just feel like the people should, you know, have a good physical therapist and whatever instabilities they are. Right, because you know, by your own admission, you said, well, there could be a cervical component, there could be a thoracic component, there could be a lumbar component. Because in other words, like you could have you know, especially if you're a loose jointed person, if you have EDS or you have hypermobility spectrum disorder. In other words, you could have literally 5 different instabilities, and they're all putting tension on the spinal cord a little. And you might say, well, Doc, come on, why do you say that? The reason why I say it is anybody who sees people with tethered cord, who've had surgery, you absolutely, after the surgery, have to do physical therapy.
Yes.
You know, so it means by definition, the surgery by itself can't cure it. And I'm not saying there's not a place for surgery. Like, obviously, I've had patients where I gave it a go, you know, the person was awesome. They got really good physical therapy, and I had to have them get surgery. But there's a lot of cases where they just do fine when we just, you know, again, good physical therapist, some good prolotherapy. So why don't you explain, after somebody gets surgery, why do you think they need the physical therapy afterwards for tethered cord? Because isn't, like, if the cord's tethered and the surgeon gets rid of the scar tissue,
should it be okay, right?
You know what I mean? That's why I'm saying that I think, you know, there's a lot more than just there's scarring or there's this or that on the cord. So what's your take on that? Because, you know, like, if you just do surgery, it normally by itself it's not so good. If you combine it with some good physical therapy, and then of course we get all the people that get retethered, right?
Yes,
that's
and there
a big
is
problem too.
I think the EDS population has a tendency. I don't know if there is a through a number on it, but it seems like they have a tendency to retether a little more frequently. I think also prehab is very important, right? Usually when those patients get to us, they are already so deconditioned because of the pain and the discomfort. They cut back on activity because there is that belief, right? Well, if you rest it, you get better. But then there's a point you rest it so much that now nothing works and you have no stability. You have EDS, you have more joint instability, you just contributed to it. So prehab is very important to prepare you for the surgery. And then obviously, hopefully you won't need the surgery, but if you do, there is the risk of retethering if the rehab is not appropriate, right? The therapist needs to understand not only the tethered cord, but also understand EDS, understand the different instabilities that each patient has, because each person is so different. And so the proper rehab to stabilize, to create a good congruency of the pelvis again, create articulation of the spine, create proper stability of the interspinal segments, it's also important. And also understanding is super important, that the therapist understands the contraindications immediately after that, because we don't want to contribute to the creation of more scar tissue and retether that patient.
Okay. Here, I got a kind of an offshoot question. Because, you know, when you got here this morning, you said to me, Doc, I thought we were going to talk about the neck, so let's just talk a little bit about the neck. You know, because there's the myodural bridge, right? So here's just a theoretical question. So what's your take on the myodural bridge, and could the myodural bridge in the upper cervical region tether the cord? And when you say that there's cervical cases of tethered cord, explain that.
I mean, it's rare, obviously, right? It's not as common. But there are patients that could tether, and there are patients, the most commonly I think it's going to be thoracic, though.
Okay.
You know, I actually working with
you're talking about here, or you're talking about the thoracolumbar junction?
No, I actually working with T8 case right now that is tethered at T8. It's not visible on
It's
not visible on MRI. And
how do you know it's tethered at T8 then?
It's the symptoms. She is actually developing. I mean, there is a whole situation. It's a very complex case. But then the artery, the most crucial one of the arteries, is exiting at T8 as well. So it's announced it's a case that cannot be surgery released. And she's developing a paraplegia. And due to that, but anyway,
because you're saying there's nummy thing around, there's numbness or something?
It's one of the severe cases. It really has developed very much far out. But I think it's the component of the Ehlers-Danlos at the end of the day. You know, it's a case with crâniocervical instability, so, you know, that will be the biggest issue, I think, there. But I do see cases on occasion with cervical, but it's very rare. Thoracic is the next, and the lumbar is the most common for sure.
I just put this here, like if you have laxity of the ligaments here, there's going to be extra movement here, you know, with the sacrum and the coccyx. So I think that's a contributing factor to tethered cord, because the cord attaches. The
cord attaches, and if the pelvis is very hypermobile, there is a lot of tension and pulling, right? And these patients have a tendency to have a scoliosis, so then everything is even more off. And then you're trying to get through life, and you are told you can hit the gym and get stronger, and everything will be all right. And then there's damage, and by the time they get to us, they get to you, they get to me, there's just so much damage that, you know, it's a lot of work. I think one of the big things I would like to hear from you is your approach to crâniocervical instability, and when do you see that patient being, you know, where you decide, okay, you know what, this is a case that's too far out, too far, you know, there's too much hypermobility, it's an atlas, an AA instability, and there is a occiput C1 instability that's too advanced for prolotherapy.
Oh, you're saying like they need surgery?
Yes, like your take when you decide that this is a case for a fusion because it's far beyond.
That's a good question.
Yeah.
So, you know, I've been doing prolotherapy since 1992, 93. So, you know, so basically 32 years. And obviously the diagnostics has gotten better. You know, we have a lot more data now with diagnostics like motion scanning. So when you get a digital motion X-ray, which you've had, you'll see that it's kind of odd. Like the first thing we do is a protracted view. So in other words, and then we do it several times. So we do this protracted view, and over time, this is just my experience, but it's a good question. When the atlantodens interval is under 3, when they do the protracted view, because again, it's a functional test.
Yes.
Now, it's not 100%, but it's a good test. When the atlantodens interval is under 3, the people normally do really, really good with prolotherapy. When the atlantodens interval is over 5, you know, in other words, the dens separates by 5 or more, that's when I do all the testing that a surgeon would do. You know, a lot of surgeons would like people to do, you know, upright flexion extension MRIs and a bunch of things, and then when their clivoaxial angle is very steep, you know, it's 125 or something, and then you get basilar invagination. You know, so normally when the atlantodens interval is over 5, when you do the MRIs, that's when you start seeing the tilting of the dens smashing into the brainstem. That's when I would start talking to them about, you know, you really should get a surgical consult. You know, so when it's between 3 and 5, so remember, so I said over 5. So when it's between 3 and 5, that's when we just have a conversation, you know, whether they should do a consult with a surgeon or not, or and you know, most of the people coming to you and me, they don't want to get surgery, you know, so they really would like to try. We would even say the surgical techniques seem to be improving and improving and improving. You know, like you know, with C1, C2 pedicular screw fixation. We recently had a gal who, you know, beautiful gal, early 20s, you know, couldn't even talk. The instability was affecting the speech and everything, because, you know, speech is the glossopharyngeal nerve and da-da-da, and then she had 100 symptoms, and then she got C1, C2 pedicular screw fixation, and she's just doing amazing. And with the occiput
in C1 instabilities, have you seen good results with the prolotherapy?
We have, because even that you can do, like we can do upright cone beams, and I can, you know, I can put people in any different position and just see if there's extra motion. As you know, that's a more tricky one to diagnose, but the hard part of prolotherapy is similar to what you do. It's usually many months, and you have to protect the investment. And because there's cell phones, what you do and I do, it's harder to do it, because every time, especially if you're a loose jointed person, every time you do this, you're stretching all the ligaments. So you're spending money to get prolotherapy.
And then you stretch it.
So that, I think that's, and the other thing too, I don't know if you found any help with this, because I think some people have issues or don't respond to what you do or I do just by, they get into terrible postures during sleep. Because, I wish we had a better way. I know there's different braces and everything, but we haven't found the end-all, be-all pillow or this or that.
That's the hardest part.
Because, they're sleeping, and a lot of people who have chronic pain, they're
moving all over.
So I think sometimes the atlantoaxial instability or upper cervical instability, that's one of the things that the patient can't control, and I can't control, or you can't control. So that's...
Yeah, and I think the other thing too, the fact that because they're in pain, they have a tendency to try to wear braces and collars, and that takes away from the cervical stability done by the muscles. So we need them to be on the brace for proprioceptive input, but we don't want them to rely on that brace or that collar, because they need their muscles. And it's kind of hard to figure out how much one patient needs versus the other patient needs. That's the other thing I have seen to be an issue. How much do you see improvement on autonomic dysfunctions when you do your prolotherapy? What have you seen?
Yeah, there's, as you know, there's lots of different things that cause that. Mast cell can cause it. When it's related to compression of the carotid sheath. Yeah. So in other words, I guess let me just say it this way. Somebody has cervical spine problems, like they definitely have structural cervical spine issues, and we document that there's compression of the carotid sheath by the jugular vein being compressed, by the tests we do. So if we find that and they're compliant with the stuff we have them do, or the physical therapist has them do, and they come for the recommended prolotherapy sessions, the results are very, very good. But there's other things that cause autonomic things. Like this is what I say, and you might have some take on this. I say there's three main things that injure the vagus nerve. One is, obviously, if you have diabetes, like you're overweight and you have diabetes, right? So that's normally not my patient population. It's probably not your patient population. Yes. My patient population, and yours is probably too, is normally 20 to 50, ages 20 to 50, probably more females than males. And the people are really active in life. Like they want to do stuff. So they're very wonderful people to take care of because they're motivated. So that's that's our patient population. So when they have issues, you can't say it's aging, it's atherosclerosis, it's all the things you see are overweight. That's normally not my patient population. So all those things don't relate to who you see and I see. So so it's not diabetes. The second thing, which people got to probably concern themselves more with, is how they handle stress. Stress by itself doesn't cause the problem. It's the way you respond to the stress.
It's your response, exactly.
You have 800 million things. You could be stressed out all day. I have 800 things, like today, like already because of this interview, I'm getting behind probably in patient care. So I could be stressed. No, but you know what I mean?
Yeah,
but I often say Jesus was never in a hurry. And at the end of his life, when they're crucifying him, he said, "It is finished." Meaning that he had the most important job of the world, which is to die for the sins of all the people, so all of us could get forgiveness of our sins. And the guy was never, ever, ever in a hurry. So you see, everybody's all stressed out. They're in a hurry and da-da-da. And the election, right? I don't watch any of the election stuff. I know who I'm going to vote for. And then Jesus taught you got to love your enemies. So so the people of the opposite party, I pray for them, and I pray for the people in the party that I'm going to vote for. that they would be wise, that they would love God, that they would they would be honest, and they would do what's best for all the people, not just the people of their party, like do what's best. So that's a better approach than I'm going to watch every night and get all stressed out. So I think, because you've seen people, think about some of the people you've seen, like they have 800 things going on, they have EDS, they got all these health things, but they come in smiling. Because smiling and laughing and knowing God loves you and being a loving, kind person and not fretting over the stuff you can't control. I can't control what the governor does or the president does or this. I have no control over it. So for me to stress over
Let's stress over what we can control.
Well, even that, it's just make sure that your attitude and what you're thinking about are good things. So this will sound very strange, but most of the time I have absolutely no thoughts. So I think the mind of Jesus is that you're in a listening mode. So I'm always trying to listen if God wants me to do something or this or that. Because people don't realize when you're fretting with 800 million thoughts, right, your brain has to process all that. So, and people have bad neck positions, bad neck posture. So all the waste products that occur because of all this mind activity, all this searching on the internet, all these thoughts, it produces waste products, and people, because of the bad postures and ligamentous cervical instability, their jugular veins are blocked. So when you're sick, you have to rest. So my advice is people need to get off of the internet, except, there's that Dr. Hauser, that guy's really entertaining. But and obviously I'm just kind of joking. But the point is, imagine, Marcia, if before somebody picked up their cell phone, there's a Bible verse that says, whatever you do, whether you eat or drink or whatever you do, do it for the glory of God. So imagine if before you pick up your cell phone, you say, how is what I'm going to look at honor God and help me or help somebody else? Because if you have a difficult client and you need to research something, that's absolutely a reason to be on the internet. But I think if all of us would just, is what I'm going to do right now honor God and either help me or help somebody else, then you pick it up, you're going to see your screen time go way, way down. Because most of us, our brains need to rest.
Yeah.
They just need to rest, and one of the ways to rest is just don't be on the internet. And
well, I think we get overstimulated by looking at so many things, right?
Yeah.
So if we get overstimulated, our brains are not able to come up to a solution.
Yeah.
So I think there's a moment for you to research, to read. I think it's valid, and I encourage patients to read and research. Yeah. But I also encourage them to take a break and analyze and listen, because not everything you read applies to you, right? And I understand that they come stressed out because they are being bullied, pushed around, told that symptom doesn't exist, that it's impossible to have that, you're too young for that, you look too good for that. There's just so many things. So they are stressed over that already because they just don't feel good. They know they don't feel good, and there is no solution for their problem yet. But I think reading, researching, and taking a break to actually absorb that and really understand, because not every headache is a brain tumor, right? But doesn't mean it cannot be. Just pay attention to what you're feeling, bring the valid points to your doctor. Don't bombard with many things, because unfortunately, this is sad that our patients cannot go to a clinician that understands at least the globality of Ehlers-Danlos patient.
Yes, true.
This is a systemic thing, right? So you might be coming in with a headache, with a compression of your jugular because you got an enlarged styloid, and you have crâniocervical instability, and then you have scoliosis, and then you have digestive issues, and then you have circulatory problems because you got POTS, and then you're going to all these doctors, and no one is putting it together. So it is stressful.
Yes.
Right. So it's sad that we, unfortunately, with the model of healthcare we currently have in the traditional medical system, we only have about, what, 10 minutes per patient.
Yeah.
So that no physicians, unfortunately, have the time to understand the entirety of that patient. But at least try to bring what is relevant, because if you bombard the physician, they also get overwhelmed because they want to help you. Yeah. So that works for the PT, that works for the nurse practitioner, that works for everyone. We get overwhelmed.
Sometimes you should just write it out, like, Doc, hey, here's the...
And yeah, sometimes we'll come across, unfortunately, a healthcare professional that really is not interested. And it's like any profession, there will be someone that is not interested, and we just have to move on.
Well, thank you for being here. You know, we got to start seeing some patients, and we got to take care of you too. So. But thank you.
Yes, thank you so much for having me.